Alrighty, well, that was really an okay place to stop. I think this is number 6. Chronic pancreatitis. You've got progressive destruction of the pancreas, and you've got fibrotic replacement of pancreatic tissues. Chronic pancreatitis happens when there is continual inflammation with destruction of these pancreatic cells. These pancreatic cells are replaced with scar tissue. Chronic pancreatitis can start with an acute pancreatitis, and that's especially the case in alcoholic pancreatitis. Almost all cases in the U.S. are caused by chronic alcohol use. The thing about cigarette smoking is that it does, whoops, I didn't mean to do that. Let me go back. Cigarette smoking accelerates the progression of chronic pancreatitis. Now, while gallstones and gallstone disease can cause repeated bouts of acute pancreatitis, you don't end up with chronic pancreatitis as likely. So most of the time, chronic pancreatitis is going to be alcohol use. It is important that if you've got acute pancreatitis secondary to gallstones, that get taken care of, because you might have had a mild case of acute pancreatitis because of your gallstones this time, but that's not to say that the next time you have pancreatitis you won't move into that very severe category. There are a few cases when chronic pancreatitis happens because of hypercalcemia, hyperlipidemia. There is a familial pancreatitis. You can have trauma of a duct that causes stricture to develop during the process of healing. So those are some, less common reasons for chronic pancreatitis. Typically, it's chronic alcohol abuse, and cigarette smoking has an additive effect to the damage. Exactly how alcohol causes chronic pancreatitis is not clear. The pancreatic ducts are obstructed with protein precipitates, causing inflammation and sclerosis, mainly in the head of the pancreas. And then you have atrophy of the gland. Pseudocysts and abscesses are pretty common. Your manifestations are going to be abdominal pain. It occurs in about 95% of patients. It's a deep pain, deep in the upper abdomen, radiating to the back, described as heavy, gnawing, or a burning feeling, lasts for days or weeks. It may disappear for several months, and then it comes back. The pain may become more and more frequent, or as the gland becomes fibrotic and atrophies, the pain may actually subside. You may have GI symptoms: anorexia, nausea, vomiting, flatulence, steatorrhea, diarrhea. The patient might be thin with a decreased muscle mass. There's a exocrine pancreatic insufficiency of varying degrees. We have a pretty large margin of reserve in our pancreas tissue. Your malabsorption and steatorrhea symptoms, those aren't going to develop until more than 90% of the pancreatic exocrine function is lost. Fat absorption is affected more than carb or protein absorption. And that's because carb digestion is aided by your salivary and your intestinal amylase. So you're not as dependent on your pancreas for carbohydrate digestion. Protein digestion is helped by your gastric enzyme pepsin and by peptidases from the small intestine, although there can be some protein malabsorptions. So anyway, it's fat absorption that's most affected in chronic pancreatitis, because your carbs and your proteins do have some other ways of being helped along the absorptive process. Malabsorption of vitamins is usually not a problem because your water-soluble Bs are absorbed through the small intestine. Your fat-absorbed vitamins, they don't need the pancreatic enzymes for absorption. However, let's not suggest that these patients don't have vitamin deficiencies, because, if the most common reason for chronic pancreatitis is alcohol, alcoholics do not have good nutrition, and so therein lies their vitamin problem. But it's not the chronic pancreatitis itself, rather it is the lifestyle that produces the deficits. Diabetes can develop, and it can be an insulin dependent because the islets of Langerhans can be destroyed in chronic pancreatitis. Serum amylase, sometimes it's elevated, but a lot of times it's going to be normal because the parenchymal tissue that forms the enzyme has been replaced by fibrotic tissues. So there's not enough pancreas there to actually secrete amylase. If the patient has diabetes, they're going to be hyperglycemic. The bilirubin and the alkaline phosphatase, those can be elevated if there's biliary obstruction associated. White blood cells may go up. ESR may go up. Those would be reacting to the chronic inflammatory process. Now the Secretin stim test. This measures the ability of the pancreas to respond to secretin. Remember that secretin is a hormone secreted by your small intestines when you've got partly digested food that presents itself through the small intestine. Normally, this hormone then will stimulate the pancreas to secrete a high bicarbonate solution into the intestine. This high bicarbonate fluid neutralizes the stomach acidity, and you have to have that happen in order for enzymes to function and allow, the enzyme then to break down the food particles and then absorption of food to happen. So what they do in a secretin stim test is they give IV secretin, put an NG tube in, into the gastric and duodenal areas, give IV secretin, and then you collect your gastric and duodenal secretions over a period of about 2 hours. People who have diseases that involve the pancreas, like chronic pancreatitis, maybe cystic fibrosis, or even a pancreatic cancer, they're going to have reduced volumes of secretions and reduced bicarbonate concentrations in those secretions. And that would be a positive stim test. X-ray might show pancreolithiasis, and they might do an ERCP to visualize the duct system to see what's going on in the area. So what do we do for patients who have chronic pancreatitis? Well, you try to prevent attacks. So, you urge patients to discontinue their alcohol use. Damage is irreversible, but the chronic and the episodic pain may stop. It happens in about half the patients who actually stop drinking. Now, when the patient is having an acute attack, the treatment's going to be the same as for acute pancreatitis when that amylase level is elevated, keeping in mind that they can have an acute attack and not experience the same degree of elevation in amylase that someone who has a otherwise relatively healthy pancreas would. Pain relief, Demerol again, antiemetics, those can be used to help the patient along. I'm going to stop here and start another segment.